Welcome to my channel. My name is Misio. In today's video, we'll discuss severe acute malnutrition. What is this malnutrition that we're talking about today? WHO defines malnutrition as the cellular imbalance between the supply of nutrients and energy and the body's demand for them to ensure growth, maintenance, and specific functions. So malnutrition is just simply the imbalance between what the child is eating and what the body needs. So this imbalance is such that the child is eating less than the body requires. Now, this malnutrition, the child needs to have specific presentations or features for this child to be categorized as malnourished. So number one, the child should have a presence of bilateral pitting edema. So when you examine the lower limbs, you find that the child has got edema on both legs. The second one will be weight for height or length less than -3 standard deviation. I'll show you a table where they measure this height and weight relationship. Then the third one is the upper arm circumference. So you measure the middle upper arm circumference. So if it's less than 11.5 centimeters for a child between 6 and 59 months, then this child falls under this category of malnourished or severe acute malnutrition. Okay, let's look at the etiology. How does a child find herself or himself in this situation where they are malnourished? So there are several factors that influence this. So the first one would be social disadvantage, where the mother or the parents have low education levels, so they don't really understand the nutrition of this child. So the other one would be family planning. So some couples have children without enough spacing. So because of this closeness, they tend to neglect other children and focus on others because of the demand. So someone has 5 children and the oldest among these is maybe 7-8 years. So it tends that they will focus more on the younger ones or the babies and neglect the others. Then the other one would be political causes. So there are some countries where they've got poor policies. So, for example, the Minister of Health is not well equipped to educate and screen for these conditions or children. So there's poor education amongst health workers, poor supply of resources. So you find that there are some areas where the ministry is not able to reach those areas and educate these women or families about this nutrition. Then you have got some places that have got wars, so government fail to control civil wars. All these will result into malnutrition in these kids. And then some beliefs. So there are some people believe that eating certain foods is not healthy for them, so they tend to be restricted to a certain diet. But remember, kids need a balanced diet. So as a result, these kids become malnourished and they fall under this category of severe acute malnutrition. Poverty is also a factor, and natural disasters. There are some times where the whole country is in drought or floods. As a result, there's poor production of food. which in turn results in poor consumption, and the child becomes malnourished. Then infections. There are some diarrheal infections, HIV, tuberculosis. So all these infections can cause a child to be malnourished because when someone is unwell or sick, the appetite tends to reduce. As a result, they do not eat according to what the body requires. Then some practices where they want to withdraw their kids from breast milk. So some weaning practices are poor. Some tend to wean them early, some late. So as a result, the child is not getting the nutrition that is required. So all these factors together are the causes of malnutrition. So even as you are examining these children, taking history, you need to consider some of these factors because, for example, you have a child who's malnourished and you discover the problem is a poor diet. So the family has got some certain beliefs or taboos that they have, that eating this is not good, we don't believe in eating this. Then you have that patient. You may treat that child, but the moment they go back home, they'll continue the same diet. So you need to advise the patient and the parents that they need to be eating these foods. So the following are just instruments or equipment that are used to measure this or diagnose these children. So you have a scale, you've got the middle upper arm circumference, tape, you've got the iron length, stadiometer. So these are just used to get the values that were discussed in the definition so they can be able to categorize this child. Whether the child is just, so there are some kids who are just naturally thin. So you may think the child is malnourished, but the child is not. So you need these things in order for you to make this diagnosis. So you measure, get these values, and then analyze them as when you categorize this child. So as you can see in this picture, we are now trying to see if this child has got a lower upper arm circumference. So we are measuring using the tape, and as you can see, the child is in the red zone. So this one automatically has scored 1 point on that list of a child who is malnourished. Then we go to the next one. We check for bioretropitin edema in this picture, as you can see. So this child has gotten the second point because both limbs have put in edema. And then on this table, this is where you have the weight for height for 2 to 5 years. So as you can see on the middle here, there's the height in white. And then from your left and right, you have colors yellow, green, yellow up to red. So one side in blue, on top there you have boys and the other side girls. So if you pick the first box in height, you find 87 centimeters. So on boys, the median should be 12.2 kgs. And then the negative one standard deviation should be 11.2 kgs. So as it continue moving, when it reaches negative 3 SD, where the child is now 9.8 kgs, but has height of 87.8, meaning the child has scored the point under the weight for height, meaning the child is now malnourished. So you can see this table for height. Let's say a child whose height is 100 centimeters. So a child is 1 meter. I expect this child to be at 15.4 kgs. Anything lower than 15.4 kg, you start suspecting malnutrition. The moment it reaches negative 3 SD in this red box, automatically the child under the weight for height has scored 1 point. When you add pitting edema, you add mid-upper arm circumference, and the child has gotten 111 in this, meaning the child is having severe acute malnutrition. So there's some other features that you may see in these kids, like in this video, in this picture, the child is has got some skin changes. So sometimes these children have some skin changes. So they will have some corneal ulcers. They will have generalized edema. These are just some clinical features that these children will have. We'll discuss them as we go down with this lecture. There's a part for examining these children. Okay, let's look at a few definitions. So we have wasting. So wasting simply refers to low weight for height, where a child is thin for his or her height, but not necessarily short. So this one is a result of short-term energy deficit. Then there is a stunted growth. So this one refers to low height for age. So expect a child with a certain height to be at a certain age. So when a child is short for his or her height, but not necessarily thin, it's the result of long-term energy deficit, also known as chronic malnutrition. Then you also have underweight. This one refers to low weight for age. When a child is either thin or short for his or her age. This reflects a combination of chronic and acute malnutrition. So there is what they call a Wellcome Trust classification. So this one just describes where the child is undernourished, where the child has kwashiorkor or marasmus, or both kwashiorkor and marasmus. So they use the presence of edema and the weight for age. So this table here is showing us the range of weight in relation to the age in percentage, and edema and the nutritional status. So if the weight of the child is 80% or more than 80% in relation to their age, and there is no edema, so edema is absent, so meaning the child is in normal state. When the child's weight is between 60 and 80% of their age and edema is absent, meaning the child is undernourished or undernutrition. If the child's weight is between 60 and 80% of their age and there is edema is present, that's kwashiorkor. When the weight is below 60% and there is absence of edema, that's marasmus. When the weight is below 60 and edema is present, this child has a combination of marasmus and kwashiorkor. So sometimes you find MCQ questions where they'll tell you the child presented with bilateral edema with a range of weight between 60 and 80% of his or her age. What's the likely condition or the nutrition status of this child? They'll put under nutrition, they'll put kwashiorkor, marasmus. So you refer to this table because this table show you the range of the weight and the presence of edema. So if the child has no edema, the weight is more than 80% of the age, meaning the child nutritional status is normal. So use this table to answer such MCQ questions. So let's discuss the pathophysiology of malnutrition. What happens in these children when they have malnutrition? So because of this low energy and nutrition supply to their organs and cells, the body goes into a system called reductive adaptation. So it's adapting on reduced supply. So because there's reduced supply and demand is high, the body has to reduce the demand to meet the supply. So there are some physiological changes that happens in these children in order to meet the supply. So, for example, if the child is hasn't a normal child, a healthy child hasn't been eating for the whole day, even an adult, the activities reduces so that the body is able to conserve the energy. This is why you find that you feel weak, so you tend to avoid certain activities. You can't lift everything or walk for long distances because your body is trying to conserve that energy. But the moment you take something, you have enough energy, you have surplus, so the body is okay to burn that energy, hence the activities will increase. But in these children, because of low supply, demand also has to be reduced. So the body undergoes this reductive adaptation system. So in this system, it has downregulated the basal metabolic rate to conserve carbohydrates, proteins, and fats. So let's read through and see what happens on a cellular level in these children. So because of this reductive adaptation, it leads to a decrease in the number and function of the sodium-potassium pump in the cell membrane, resulting in higher intracellular sodium and low or loss of potassium into the extracellular space and hence into the urine. So from the get-go, because of low energy, remember the ATP pump requires, the sodium potassium pump requires energy to function. But because there's low supply, even its function is reduced. And the numbers, so in short, other pumps are reduced or cut off so that they do not disturb this balance that the body is trying to maintain. As a result, there is the decrease of the sodium potassium pump, which results in increase in sodium in the cell and loss of potassium to the extracellular space. So already the child has losing potassium, which is also lost in the urine. And remember, potassium is also used in muscle contractions. So as a result, the net effect are an increase in the total body sodium, low plasma sodium, and depletion in total body potassium. So already things have started going south. the total body sodium is increased. Why? Because the pump is not pumping out the sodium out of the cell. So the cell is now packed with sodium. So the total body sodium goes up. But in the blood, the sodium levels go down because there's no exchange between inside and outside the cell. So all the sodium now is, the majority of it is loaded in the cell. And then remember that this potassium again is not being pumped in and out, it's just outside in plasma. As a result, it's being urinated. So there's depletion in the total body potassium. So the physiological processes are minimized and the function of all major organs is impaired. The kidneys are less able to excrete the extra sodium. Cardiac muscle atrophy and decreased potassium contributes to poor contractility and reduced cardiac output. So as you can see, already problems started arising. That's because of sodium and potassium. So because potassium is low in supply, cardiac contractility becomes poor. So you have reduced cardiac output. So because there's reduced cardiac output, there's stagnation of fluids. As a result, this fluid starts leaking in. This is why people with heart failure tend to have edema. So already from this problem, we are seeing that edema has slowly started rising because of this reduced cardiac output, because of cardiac muscle atrophy and the reduced potassium levels. So in the digestive system, the digestion and nutrition absorption is impaired by decreased production of acids and enzymes and decreased gut motility. So already there's poor supply of energy. So the cells starting from the stomach all the way has got low supply of energy. So their function has been reduced. So in the stomach, production of acid is reduced, production of insulin is also reduced, production of enzymes is also reduced, gut bacteria will increase because remember the immune system is also reduced because there's low supply of energy. So these children tend to have diarrhea because when gut bacteria increases, they produce toxins which retain water. As a result, they tend to have diarrhea. And because of this diarrhea, there's malabsorption. So there's diarrhea, which is going to cause malabsorption. On top of that, the cells are in no supply of energy, so absorption of nutrients is also reduced. So even when the child has not diarrhea, but again, the cells that are supposed to absorb these nutrients from the food, that little food that the child is eating is also reduced. So already the child is slowly falling into this vicious cycle. So again, remember, because there is reduced supply of everything that the body requires for growth and function. So the pancreas supply of energy is reduced, so its production of insulin is also reduced. And remember, insulin is needed for glucose to enter the cell. So this child eats this low glucose because of the factors that we have listed, or because of that those listed etiologies, maybe because of poor nutrition, maybe there's drought. So this child is given a small biscuit or sweet to eat. But again, this energy is poorly utilized because of reduced insulin. The cycle is getting more vicious. There's reduced insulin and growth factors. Already, the child gets low energy from outside. That low energy is poorly utilized by the cells. Then the hormone that is required for the cells to grow or activate growth is also reduced. So, when the child is healthy, and then due to those factors that we have listed, started slowly falling into malnutrition, the body will detect this and will try to compensate for this low supply to meet the demand. What happens is there will be a rise in these growth hormones and cortisol in the early phases. But what this does is that if the supply is not met in relation to the demand, this can in turn cause other problems. So what happens is there will be a rapid gluconeogenesis with resultant loss of muscle mass caused by use of amino acids, pyruvate, lactate. Later, there is protein conversion phase with fat mobilization leading to lipolysis and ketogenesis. So this is where now the child becomes thin or wasted, because in the early phase the body is trying to compensate, so it will trigger now lipolysis, gluconeogenesis, burning all the other reserves that the child has. All the proteins will be used up, the fats will be used up, and the child will have muscle wasting, then the child will be thin. Remember that this gluconeogenesis and lipolysis is using the proteins and the fats. And remember, cells have these proteins and these fats. So as a result, it will consume all the reserves, and then it will start attacking now the body organs and the muscles, so that it can have some energy to survive. This causes atrophy of organs, and one which is usually affected is the thymus and the lymph nodes, the tonsils, and these are important in the immune system. So because of the use of these proteins and fats that these thymus, lymph nodes, and also tonsils require for defense or for the immune system, and they become atrophied, meaning their function also reduces. Hence, these kids will be prone to infections. Even the response to infections will be poor. So you find a child who's having an infection but is failing to mount a proper immune response against this infection because of this atrophy in the thymus, the lymph nodes, and the tonsils. And remember, most of the proteins has been used up. So even mounting a proper immune response is reduced, because you need the body, the immune system needs protein to make cells. Remember, cells require proteins and energy, which this child does not have. And then, of course, and also remember, in the gut, there are bacteria. So because of this poor immune system, there will be bacterial overgrowth, to cause diarrhea, and because of the use of proteins to make energy. Also, there's also atrophy in the GI. As a result, there's poor absorption. There also be reduced drug metabolism because some drugs need to bind to proteins like albumin, but these proteins have been used up to supply energy. So as a result, there's poor drug metabolism. So these drugs are not bound into the proteins to be transported around the body. So even as you are treating infection that should clear in a week can clear more, can take longer than that because of this problem that they are having. And of course, central nervous system also be affected because there's low supply of nutrients, energy. So you find that even uh, the the development of the brain will be slow and poor. As a result, these children, their intelligence will be lowered, even their attention will be lowered. So you find this child's response is very slow because the central nervous system growth is also lowered. And then there's also some electrolyte imbalances that come because of this some severe acute malnutrition. So there will be, of course, potassium, which is excreted in urine, and also magnesium, and others like zinc, copper, and so on. So this should be given when you're managing these people or these children. So let's do initial assessment. How do you assess these children? So a child in clinical hospital comes in and you are seeing these features. You're seeing there's edema, you're seeing there's weight loss, you're seeing there's the upper arm circumference is in the red zone. So you're seeing all these features. You're seeing color changes of the skin, hair. You want to direct your assessment to someone who has malnutrition. So this is what we're going to discuss now, so that at least you can now focus the assessment of this child, so that you can pick out the causes and other features that they may have that you want to manage for a patient with malnutrition. So in the history, you want to assess for danger signs or emergency signs and take history concerning recent intake of food. Remember, these children need food. So in your history, you need to know what kind of food this child had eaten before they came or before you saw them, so that you know what else to give next. Because one thing you want to avoid in these children is overfeeding. So for example, they tell you, this child, you have assessed the child and you have seen that this child has malnutrition. Then they tell you, no, just feed this child some porridge with peanut. So already there's some food in the stomach that the body is going to utilize. But you know that this child requires food. So you will not rush into feeding this child because you're avoiding refeeding syndrome. So you need to be cautious. So you need to ask where the child has taken anything. So because if the child has taken something and you knowing that the child needs food, you load in more food, you may tip the child in feeding syndrome. So this is why it's important to know what the child has eaten, the usual diet before the illness. So this will also give you the picture of what the child uh, has been before the illness, and probably what would have caused the illness. In a breastfeeding history. So there are some children who are not breastfed. They are given formulas so that you take into consideration. Then ask about duration and frequency of the diarrhea and vomiting. Of course, the type of diarrhea, water or bloody diarrhea. So remember, yes, the parents would say the child will have given his child some porridge, but they later tell you this child every 3 or 4 hours he or she has diarrhea maybe twice in just a short period. So already you know that the child is not able to absorb enough nutrients. So even if we have fed this child just like 10 minutes ago, the chances are high that the child won't be able to absorb enough nutrients. So you plan according when managing these patients according to this information that you've gotten in the history. Loss of appetite. So they tell you, no, this child is not eating well, poor appetite. So the mother will say, no, try to feed her or him, maybe just 2 3 spoons, and the child stops feeding. So from there, you may want to find alternative of feeding this child, because you need to be feeding this child frequent when managing this child, but you need a route of feeding. So you may be planning to insert an NG tube for feeding. So this information here would also help you to plan the management of this child. So they tell you, no, the child has good appetite, it's feeding, is able to finish the whole bowl, has no diarrhea. So you know that, okay, the child has no diarrhea, is able to feed, then there's no need of NG tube. We just prepare the formula and start feeding this child according to the management or the plan. Then ask the family circumstances. So I try now to get more idea on how this child would have found him or herself in this situation. So look at the socio-economical status of the family. So maybe the family has no house, they have nowhere to stay, they'll be running for months because of civil wars. So you know already they are in a poor economical status because no one is working, they're always on the run. So you may not, probably this is the cause of the malnutrition in this child. So even as you're planning discharging this child, you need to take that into consideration. The income, the housing, food and water supply, and sanitation. So some people may be in the same place, there are no civil wars, it's in a peaceful country, but they have poor income. So they're not able to meet the required nutrition or diet for the child. So you may want to help them with these things: housing, food and water. Then you want to ask about if the child has been coughing for more than 2 weeks. Remember, poor immune system. So you're looking for respiratory infection. Remember, on the other side, that's about diarrhea. You're looking for GIT problems, because if the child has got a respiratory infection, this may affect how you're going to manage this child. You may want to put this child on oxygen longer than the usual. Put on drugs. And remember again, there's poor drug metabolism. So if the child has maybe pneumonia, you have to consider all these things, because now you are picking out these complications. TB contact. Remember, poor immune system with TB contact. It's high risk factor. So you want to consider all this. Recent contact with measles, known or suspected HIV infection or exposure. So you want to check both parents, the HIV status, because this can also change how you manage these children. Then you go further and ask about the birth history. So you're asking is related to this child, the birth history, the weight, whether they were spontaneous, vaginal delivered, or to the cesarean section, their immunization history, very important. Have they taken all the vaccines for their age? Are they up to date? Check their developmental milestones. Did they have any delay? Have they achieved all that? So you find a child who is expect a child who is 5 years to be able to speak certain words or construct proper sentences that you are able to understand for their age. But you find this child is only speaking one or two words and they are malnourished. That means you may suspect that there's poor development. So even as they recover from this malnutrition, you'd want to put them in a place where they'll be able to learn and catch up. Ask about any past medical history, any respiratory infections, again, same thing, TB, measles. Ask about these things. Ask about family history, parents, siblings, health status of the siblings, family occupation, education. But all this information is going to help you on how you're going to manage this patient. Now I come to physical examination. So there are a few things that you want to check in these children as you're examining them. Of course, those three things that were mentioned earlier in the definition, those ones you just have to examine and check them in these children. The edema, upper arm circumference, and the weight for height. So in these children, you want to check for shock. You want to check with their lethargic or unconscious with cold peripherals. You want to check the capillary refill. You want to check the pulse, whether it's rapid or slow. You want to check the blood pressure. Remember, there's poor cardiac output because of the potassium. So they may have a low blood pressure. They may have a low capillary refill. They may have a rapid pulse because they're trying to compensate on the low output, the low cardiac output. So you need to check all these in the cold peripherals. You need to check all these. And then you manage according. Signs of dehydration. Though they are not reliable in some, because these kids tend to be overloaded with fluids. Remember, they have edema. Some even have generalized edema. You check for anemia. Remember, these kids low energy supply, low nutrition, so everything is low. Production of everything is low. Together with the HB. For example, this child goes for like 3-4 days without eating, and the only time this child eats, just a small piece of bread. So this child has gone before a month without iron. You expect this child to be anemic. So this child will have anemia, so they will have pallor. You check all this, find that they tend to have pallor. Eye signs of vitamin A deficiency. Remember, they have got deficiency. So they said they are deficiency in a lot of things which affect a lot of systems. So they can have dry conjunctivitis, they have corneal ulcerations, they have red eyes. So you check all these signs. So even as you are managing these kids, feeding them, you need to make sure that you consider giving vitamins. But iron, in the management, show when you get to give iron, you give iron cautiously. So the problem with iron is that the body is not able to utilize it immediately. And remember, these kids are in state of poor immunity. The moment you introduce iron, bacteria utilize this iron and multiply and cause infections. So I'll explain in disease management when you give iron, why do not give iron at this point. And then these children may tend to have fever. But some will not have fever, but they have infection. And the reason why they may not have fever is because the body does not want to utilize energy to produce heat. This is why they even tend to have cold peripherals. And remember, pure immune system. So the body has infections, the body is not able to detect. As a result, it's not even able to initiate a fever. They may have mouth ulcers, skin changes. They may also have some infections, ear infections, eye infections. So you want to check all this in these children. Then you proceed to doing some investigations. So you want to do a septic screening. You want to do a full blood count where you find anemia there. You want to do a stool microscopic culture and sensitivity. You are checking for parasites, infections there, bacteria. You do a urine culture, microscopy and sensitivity. You're checking for infections. Chest X-ray, checking for respiratory infections. TB test available, so you can even take sputum with gene expert, because sometimes you may find that yes, they are the TB contact, but the parents are not able to remember because maybe the patient was just coughing and came to visit, so they don't know whether the person who came on TB or not. So you just want to screen for that. You also want to do HIV test in these children, a malaria test. So you do an RDT, blood smear for malaria parasite. You want to check the kidneys. So you check the urea, the creatinine, and the electrolytes. Remember, they're usually hypokalemic because they lose the potassium, they have high intracellular sodium. So you check the electrolytes. Blood sugar, very important. Remember, they are not eating well, they have used most of the energy, so they are most likely in hypoglycemia. So you check the glucose and you manage accordingly. That's why in the 10 steps of managing severe acute malnutrition, glucose is number one. This is why the body will do everything it can to maintain blood sugar levels. It will burn the fats, use the proteins, break down muscles. Then the child will be wasted, will be skinny, and all that, just to maintain blood glucose for the brain. That's why blood sugar very important. You take the blood sugar, don't waste time. When the blood sugar, you start feeding. But remember, you need to feed with caution, because you're avoiding feeding syndrome. So always assume that the child is hypoglycemic. You quickly give dextrose. So we see how we're going to manage these children in the part 2. So this is just part 1, where we have evaluation, uh, the initial assessment, the history, the pathophysiology, some signs and symptoms, some pictures, how these kids will look like. And then you can make some differentials. So the child may have marasmus or kwashiorkor. Remember that we all trust classification more than 80%, between 80 to 60%, less than 60%, their presence or absence of edema. You can put whether it's kwashiorkor or marasmus. Again, they may tend to have. So we may think it's kwashiorkor, but it's just nephrotic syndrome because it also presents with edema. Then they maybe just congestive heart failure or liver disease. So maybe the child has a malignance or just some infections or other chronic conditions. So we give you differentials and give you diagnosis. So in the next video, we'll learn how to manage, we'll learn the 10 steps of managing severe acute malnutrition. Why you start with sugar, why you don't give iron, why you give slowly, why you stop at 2 weeks, why you start this management at 2 weeks, why you are giving this kind of feed, why is this feed important, why aren't you just feeding until the child is full, why are you feeding every 2 to 3 hours, why are you doing what you are doing. That's what we will learn on managing these patients.